When we do a pre-cataract screening, most important thing is that we find out if there are any abnormalities, anything that will result in a surprise afterwards. We don't really like that. So if we have a machine that can comprehensively look at the different phases of the anterior segment, especially in terms of corneal abnormalities, or even little things like densitometry of the cornea, which can give a hint to a Fuchs disease or endothelial problems. And you will be not surprised that there are really patients that even forget that they had 15 or 20 years ago LASIK or PRK, and they don't tell you, or if they don't not ask about it, and then you can see that. And there are also other optical features that are very important, especially if you're in the premium lens channel, talking about multifocal IOLs, talking about asphericity of IOLs, and so on and so on. So all this can be measured with one device, the Pentacam AXL, as you see here. And as you know, the Pentacam has one of the advantages is that the axial length and the 3D scan measurements are taken at the same time, or in succession, so to say, on the same measuring axis, yeah, which is very important. Then there are usual things included nowadays, that you have a database, that you can optimize the constant, and the software and also the hardware of the machine is constantly improving, so that there are updates on the software which allow you to measure, especially also what the axial length is related, even more dense or harder cataracts with better accuracy. Let me just start with an example where I was actually surprised that the IOL Master 700 that we use very extensively and in a lot of refractive patients was a little bit wrong compared, it's just a minor case, but compared to the Pentacam AXL. A 55-year-old male patient came for refractive lens exchange and presbyopic lens exchange. So his uncorrected visual acuity here, as you see for distance, was 0.6, 0.8, and for near only 0.3, or 20/30, 20/60, as you can see here. If you correct him, he had excellent vision, yeah, better than 1.0. So, but he didn't want to wear glasses, and he hated his readers, so he wanted to be done something. So our normal way is to do the IOL Master, calculate the appropriate values, and let's look at the left eye, because we did that at first. With the IOL Master, we calculated here a lens plus 20 diopters, and it would be exactly at 0, more or less, with the calculating for a Zeiss trifocal intraocular lens. So we did that, and it came out pretty okay. He was 20/25 uncorrected distance and near, but he ended up hyperopic, a quarter of a diopter. You may say, oh, it's not so important, but if you have a refractive lens exchange patient and he loses 1 or 2 lines just for half a diopter or something like this, you wonder why is that, especially if you're planning to do the next eye accordingly. So we looked at the data from the Pentacam. There was not much difference in terms of the measurement of the cornea or corneal shape. There was slight difference in the axial length, and if we look at the calculation with the Pentacam, it predicted actually a hyperopic outcome of around a quarter of a diopter. So the Pentacam, I wouldn't have used this. I would have actually gone to 20.5 diopters to make sure that I get him at least to ametropia or slightly myopic, a quarter of a diopter. And accordingly, the suggested IOL power would have been 20.5, and this would have been better in this individual case. The other eye, the right eye, we see that there's some astigmatism here. So we were looking for toric multifocal or trifocal lens. Here, the IOL Master calculated a lens with 1.5 diopter torus in it, or the spherical equivalent would have been 20.75. Which then also ended up in a very nice result. So binocularly, this patient was happy, regardless this quarter of a diopter. But as I said, the hyperopic shift is something that we don't like after cataract surgery. Myopic is okay. And with the second eye, the right eye, the IOL Master, the Pentacam also calculated the 20.75, so they were very accurate. So this can happen in individual cases. So we were then interested, of course, how is it if we do a real study and if we compare all these values? Of course, there is some variability in measuring. Very important when you measure these eyes that they are untouched, not measured before with a a planation tonometry or put some eye drops in before. You should measure them really at the beginning of the whole thing. It's very important. So we did a study here. It's ongoing. 163 eyes are so far included. And we did 3 consecutive measurements per eye with both devices. We didn't have any real exclusion criteria, so it was not really of interest if the patient has some pathology. It was more or less a real-world scenario where we looked at everyday performance. So there were very dense cataracts and clear lens extraction. Everything was in there. And we measured all these things, as you can see here. And one thing that is important when you look at the data later on, we looked at all measurements which has the OK value here presented. So you can make a measurement, but the IOL Master or the Pentacam will tell you it's not really optimal. Yeah? It doesn't give you the OK, but if you look at it and the patient is difficult to measure, whatever, you still can rely quite a bit of it. So, but here for the scientific evaluation, we only included these values here to look at it. Go on. Kind of stuck here. Can we go on? Ah, okay. So here, if you look at the success rate in terms of everything is okay, yeah, with these measurements, we could see that interestingly, IOL Master 700 several times gave a little bit more non-OK, as you can see here. And in the Pentacam AXL, 85 to 87% were OK during that time. So how was it if we go? Oh, doesn't go further. Can you go on? Oh, okay. The measurements of the axial length sometimes show a slight difference, but between the IOL Master and the Pentacam, on the third point after the comma, and slightly lower values sometimes for the Pentacam, but the whole composite usually shows almost the same outcome in terms of the overall measurements of these eyes. But there's a systematic way in it. If we look, for example, at the axial length, as I said, the better, 5% better was the Pentacam, and also the covariance, so the accuracy of the measurement was slightly better actually in our study here for the Pentacam. But beware, this is all only for if everything is fine with the both devices. If we look at anterior chamber depths or horizontal wide to wide, we also saw slightly better covariance for the Pentacam here. For the interchamber depth, the IOL Master was slightly better, and for axial length, as I already said, the covariance was better with the Pentacam. But the absolute values did not significantly different from both devices, so it really is more or less the same if you measure with them. It has no real huge impact. Next slide. There's something wrong here with the slide going forward. Just go on, next slide. Okay, keratometry values, again, very good and very comparable data. As you see, covariance in terms of distribution was slightly better for the Pentacam AXL. The astigmatism were almost identical if you look at the overall values. If we go a little bit more in detail, here these are the overall values. If we go for astigmatic values more than 3/4 of a diopter, we also didn't see any difference between the two devices. So we can say that we have in 70 to 80% absolutely perfect values where all the quality criteria are fulfilled. We can use the Pentacam AXL for the whole procedure. We don't need to switch between two machines if we want to have a comprehensive pre-cataract screening of the patient and have very reliable values. Interestingly for us was that the Pentacam AXL, which still is kind of new also in terms of the development of the software and everything, has a very good repeatability in our cohort, as to say. The Pentacam, I think, is more than equivalent to the IOL Master 700 here, and as the company is continuously working on it, also with these kind of studies, I think we can make it a very perfect machine for pre-screening visit and calculation of our IOLs for our patients. Thank you very much for your attention.